Thank you so much for your introduction, and it's so great to be here. And as Abdi mentioned, I am from London, so it's quite a long flight to come here, and the first few lectures have been absolutely phenomenal. But to be honest with you, I've been super nervous because my lecture has nothing to do with anything that we've spoken about this morning. So what I'm really going to be talking about is predictive diagnostics and what that actually means. And I think we've kind of covered who I am, but I'm a dentist based in London. I do a lot on salivary diagnostics. Unfortunately, there's a coined term of the saliva queen. I'm not sure if I like it or if I don't like it, but apparently that's now my nickname. But I also do a lot of work for NASA, the European Space Agency, and I'm on the innovation board for Harvard as well for salivary diagnostics. Now, on top of that, we've got the Health Society, and this is my lovely clinic in London. And the whole point of opening this clinic was really to try and make dentistry understandable. So I think if you look at our medical colleagues who, you do a blood test, for example, you don't need to be a doctor, but you understand what that means. You understand high or low or good or bad. But with dentistry, it's really hard for dentists to actually show what's going on in a patient's mouth and for them to understand. So when we're saying you've got pocketing, you've got furcation involvement, you've got a microfracture, a lot of patients don't really understand what that means. So my main goal has been really to try and make what we do in our diagnostics quantifiable and therefore understandable to patients. And we're very prevention focused, so our whole idea is that I don't want to ever pick up a drill. I don't want to be placing implants if I can. I don't want to be doing fillings if I can. And I think as you'll see in this lecture, with the generational changes, you're going to be seeing less and less restorative work in your younger patients because we're doing a really good job. So if you look at your 16, 17-year-olds at the moment, a lot of them don't need fillings. And imagine those kids are going to become 30, 40 years old and they've never had a filling. So we actually need to understand how to prevent that in the first place. And on top of that, I also do a lot of saliva testing. So I founded a lab called THS Labs. It's based in London, and we basically collect lots of data from our patients, and we've created a test that combines shotgun metagenomics. So we look at hundreds of bacteria with genetic mutations, and we look at the patient's nutrition, their age, their medical history, to then actually predict their risk of common oral diseases like gum disease and decay, but then to also understand how that's connected to the rest of the body. So, what is the future of healthcare? And I think most of us can now start to see that actually it's all about being quantitative, it's personalized. I'm sure a lot of you here are wearing some sort of wearable. I'm sure you've done a blood test in the last couple of months. We're all obsessed with trying to track what's going on in our bodies. And I think what's really important is that we actually start to see why dentistry needs to change and why we need to become more diagnostic by looking at the generations that have come before us. So we look at the greatest generation. They were born between 1928 to 1936. And their major events were things like Great Depression, World War II. And they're very kind of formal. They're very cooperative people, very selfless. And what's most important is their health attitude. So they're very much doctor knows best. Whatever the doctor says, I will do it. They won't start questioning, you want to do an onlay, and they're not going to say, oh, actually, well, doctor, I've learned on ChatGPT that actually maybe a resin, modified composite might be better than this. They don't know anything. They say, okay, whatever you say, I will do. And they're very much more into traditional medicine. And then we move to the silent generation, who are pretty similar, and they are very respectful of authority. And again, it's very much doctor knows best. It's all about traditional medicine. It's nothing to do with being holistic. They just want to have traditional medicine, and they will listen to whatever their doctor says. And then we get to our baby boomers, 1946 to 1964. And their major events were the Cold War, women's rights. They're quite optimistic, they're inquisitive, they're competitive. They've just started to kind of integrate digital technology into their workflow and into their lives. And again, they're still doctor knows best, and for them, reputation is everything. So they'll travel an hour to see a dentist because they heard from their friend that that dentist is really, really good. And all they care about is reputation. But again, they're very much traditional medicine based. And then we go to Generation X. And Generation X, they're much more individual, they're much more independent, and they're very skeptical of authority. And for them, they're loyal, but they're cynical. They might be ones who ask you a few questions, but they'll still go ahead with your treatment plan. And again, they're still very much into traditional medicine. But then what starts happening is you get into the millennial generation. And these are your 19-year-olds to your 35-year-olds, and they had the technology boom. So they were born really with technology. They're very savvy with their phones. They're optimistic. They all want to make an impact. They want to collaborate. They're quite selfish. So it's all about me, me, me with them. And for them, internet knows best. So all of a sudden, we're seeing a transition where now it's not doctor knows best, it's internet knows best. These are the ones who are going online, checking, okay, I got an ulcer, what does that mean? And then they're freaking out because they think they might have cancer. Okay, these are the types of patients. They want easy and open communication. They want online booking. They want all of their consent forms to be digitally sent to them so they can sign it. They want DocuSigns, all of that. So these people are now, you're seeing a bit of a transition in the type of dentistry and the type of healthcare that we need to be providing to this type of generation. And then you've got your Gen Zs. So you're 1994 to 2009. And for them, they're quite mistrustful. And they are also, they're always connected, they're multitasking. They're probably sitting at a conference here, writing an email, posting on Instagram, buying something for their dog at home. They're doing 10 things at the same time. And for them, their patient knows best. They think that they know a lot better than maybe healthcare professionals. And that's usually because of the internet, which has influenced them to make their decisions. And for them, it's all about being holistic and for prevention. So these are the types of patients who might actually say, you might say, okay, you need to have this tooth taken out. And they say, no, I'm not going to have that taken out. I was looking online, and I think that if I do X, Y, Z, and I change my diet, I might be able to keep this tooth. So it's a very, very different type of mindset that we're starting to see. And then we've got your Generation Alphas, who I don't think any of us here are Generation Alpha, but I'm sure many of you have a Generation Alpha at home. And they are the most intelligent, they're tech-empowered, they're very passionate. They don't have very much human contact, particularly because of COVID. But again, for them, it's very much become patient knows best and internet knows best. And this is where we have the self-optimizing generation. And this is the generation who are doing their juice cleanses, they've got their wearables, they've become dairy-free, they choose their milk, health is wealth. It's become the trend at the moment. Everyone's obsessed with kind of being self-optimizing and being the best version of themselves. So really the future of healthcare is fueled by that generational change because our patients want that. So we're looking at things like telemedicine now. We need to be a lot more preventative with the way that we're working. We need to be a lot more holistic. We need to think about the body as well as the mouth and how it's connected. And we also need to understand that health is not just about taking the right medication, but it's about your wellness, your exercise, nutrition. Are you doing breath work in the morning? It's changing, and we need to understand that. These types of patients, they want transparency in their costs and their risks. We are a highly litigious profession, and it's unfortunately on the rise. So we need to understand how we can cover ourselves the best way possible. And these types of patients, they want tracking health indicators. They want to understand what you're talking about. Because if they don't understand what you're talking about, they'll go online and they'll search it and they'll make up their own decision. So this is where communication is really key. They want easy access to their data, so there's a lot of these apps now where you can collate all of your blood test results and everything onto an app and compare different things and personalize your nutrition. These are the types of patients we're now seeing coming through our doors. And ultimately, they want to make an informed decision. It is patient knows best, but they do deserve to have all of the information available to them. So I guess going back to my first question of what is the future of healthcare, what is the future of dentistry? And the answer is quantitative and personalized dentistry. So what does that mean, personalized dentistry? Does that mean you need to floss more, or you should eat less sugar, you've got loads of cavities, you're doing everything wrong, or you don't brush your teeth and that's why you have gum disease? Or is it that actually, let's just watch this lesion, maybe we fill it next time, we'll see what happens, maybe floss a little bit better and hopefully that cavity doesn't become any bigger. Or just, you should change your toothbrush, you don't know how to brush your teeth properly. And unfortunately, I'm sure all of you here don't do that, but there are a lot of dentists out there who do that. And the reason I put this up is because actually we all are practicing personalized dentistry every day. So when you see something like this and you think, okay, so massive fracture, and everyone will be personalizing their treatment based on what the patient needs and what they want. So some people in this room might say, okay, I'm going to do a lovely MOD composite. Another one will say, actually, I'm going to crown this tooth. Another one might say, I might do an onlay. Another, everyone's got different treatment plans. And part of that is personalizing it for that patient. But unfortunately, a lot of other areas of dentistry, such as perio, we don't really personalize things as much as with restorative work. And so for me, this is what personalized dentistry is. This is the idea that we actually do start testing bloods. And if you don't feel comfortable doing it in your clinic, you should be able to work with a doctor who's nearby. I built my clinic by actually knocking on doctors' doors, nutritionists, functional medicine practitioners, and telling them the connection of the mouth to the rest of the body, and telling them that we should collaborate, because if your patient has good oral health, their general health will be a lot better as well. So we actually regularly do blood tests in our clinic. We also have a nutritionist. We have a functional medicine doctor in our clinic. So we give nutritional recommendations. There's so much research coming out now, particularly for something like caries or for perio, where nutrition plays a massive role in it. And then the idea of detecting and treating your airway and breathing issues. So now more and more dentists are starting to understand that actually, how narrow is the palate? Is that going to impact how they breathe? We're not just thinking, let's just make things straight and pretty, but we're actually starting to think about that patient and how it impacts the rest of their body. We're also trying to understand to prescribe oral hygiene. So we shouldn't be going and telling every patient to use exactly the same toothpaste, exactly the same toothbrush, the same TP brushes, the same mouthwash. We need to be personalizing that more. And there's a huge kind of advent of artificial intelligence coming along, which is helping us make those decisions and track things better. We're also trying to actively prevent disease, and we're going to cover that a little bit more. And as I said, collaborating with other healthcare professionals, which is a really big practice builder. So we're going to start on oral microbiome testing, and this is my favorite thing. And I thought, after all of the lectures this morning, this is how I'm trying to fit in with you guys. So I'm sorry, Javier, if I've taken anything from you, but you guys are all about bioemulation. I'm all about biome emulation, and trying to actually recreate the oral microbiome that we had at birth. And every time, we're doing our new habits and changing things, we're impacting our oral microbiome, and that's having a downstream effect on our oral health, but also on our general health as well. So what is the oral microbiome? And the oral microbiome was discovered by a wonderful guy called Anthony van Leeuwenhoek in 1683. And he was a bit weird. He basically decided not to brush his teeth for a couple of days, and he had got this kind of white film underneath his fingernail, put it under a microscope, and lo and behold, he drew the first ever photographs or drawings of oral bacteria. And this was the first time that we actually understood that the mouth is not aseptic, that there's actually living microorganisms inside the mouth. Now, fast forward a couple of hundred years, and we now understand that there are 700 different species of bacteria in the oral microbiome, which make 2 billion bacteria overall. And this makes the oral microbiome the second largest microbiome after the gut. And how many of you here have done a gut microbiome test or know about the gut microbiome? Okay, fantastic. So a lot more people are into that. But oral microbiome testing and the idea of the oral microbiome is much, much kind of earlier and younger. And what's interesting about the oral microbiome is that it's very heterogeneous. And what that means is that within the same mouth, you have multiple ecological niches. So if you think about the bacteria that would want to live on the teeth versus maybe warm and wet area underneath the tongue, or at the very back near the tonsils, these are all very different environments, and therefore different bacteria will want to live in those specific areas. Now, on top of that, we have our little kind of Chinese buffet service over here, or your saliva. So your saliva, travels around, and it gives all of the right food, enzymes, proteins to these bacteria. So these bacteria have their own little environments. Saliva's traveling around. They take the proteins and the food that they need, and they basically survive like that. Now, on top of that, obviously not you guys because you're all into bioemulation, but a lot of dentists out there will not be thinking like that. And they're adding a lot more ecological niches. They're creating plaque traps. They're creating, overhangs. They're creating pore margins. They're creating dentures where plaque is, collecting underneath there. And again, we're adding even more ecological niches and more places for bacteria to start surviving. So the oral microbiome in health is a really nice balance of symbiosis. So we all have a few bad bacteria in our mouth, but that's okay because we have good bacteria in the mouth as well. However, in disease, what happens is you get this shift into what we call dysbiosis. And this is where you have high levels of bad bacteria, which kind of overwhelm the good bacteria. And things that can push that shift are things like your diet. So if we're having a high carbohydrate diet, we're not eating properly, then of course it's going to change the sugars in our mouth and then therefore impact the bacteria that's able to survive. Poor oral hygiene. So your teeth are the only non-shedding surfaces in the whole body. So if you don't actually brush your teeth and mechanically remove the plaque and biofilm from your teeth, no one else is. And that bacteria can keep on growing and growing and causing problems. Whereas if you never had a shower, technically we kind of do self-wash because our skin sheds. So actually our teeth are very, very unique with that. Antibiotic agents, so of course sometimes we need them, but they are, a bit of a nuclear bomb in the mouth. They really just wipe out everything inside the mouth. Medications, so there are certain medications that will impact the oral microbiome, make the saliva more acidic, change the way that we have, that these bacteria metabolize, and then reduce saliva. So xerostomia for me is one of the most important things for the oral microbiome. And having a dry mouth really impacts your oral microbiome. And it goes back to, imagine that Chinese buffet service, where these bacteria, they're waiting for their food, their protein, but there's no food, there's no saliva, there's no transport medium. And that's where, again, you start seeing that oral microbiome shift into dysbiosis. Disease as well, genetics, and this sometimes, some people, I think, this is a bit of a newer kind of thing in the sense that a lot of people always said, oh, genetics don't play a part. And I'm sure we've all had that patient who says, oh, I've got bad genes, that's why I have cavities, or, my mom had gum disease and that's why I have gum disease. And we all kind of rolled our eyes and we're like, no, you're just being lazy. But actually, there is a very strong genetic component in a lot of oral diseases, and we're going to go through a few of those. Smoking, which of course is going to impact your oral microbiome. So I guess the question is all bacteria or biofilm bad? And the answer is a little bit more difficult than just saying yes or no. So we really need to go through the timeline of the oral microbiome and understand what we know about it. So Anthony van Leeuwenhoek, he discovered bacteria in 1683. He didn't know if it was good or bad, he just knew it was there. And then in 1930, we had the non-specific plaque hypothesis. And this was the idea that all bacteria cause disease. So the more bacteria you had, the more disease you had, basically. And this is where we see the advent of a lot of antimicrobial mouthwashes, which were advertising, kills all bacteria, kills everything. And then in 1976, we realized that actually it's only specific bacteria that causes disease. And this is where we had the rat studies by Keyes, who understood that actually specific bacteria like strep mutans, when they had the right substrates in the mouth, would cause things like decay. But if you didn't have that bacteria, you wouldn't get decay. And then in 1994 was the ecological plaque hypothesis, and this was the idea that actually disease is the result of an imbalance of the microbiome, and this is caused by ecological stress. So this is where we're starting to see a little bit of host immune response. It's about the body as well. And then in 1998, Sokransky came and he said, actually, it's much more complex than that. He actually called it the complex theory. And this was the idea that actually it's not as dichotomous as saying you've got good bacteria and you have bad bacteria, but it's more of kind of a pyramid. So there are specific bacteria at the very top, which are your red complex pathogens, which are extremely aggressive and very, very bad. And there's some bacteria which are not so bad, maybe bad in some, but okay in others. And then there are other bacteria that are really good. So there's kind of more of a spectrum or a pyramid of bacteria. And then in 2012 came the keystone pathogen hypothesis. And this was kind of based on the Human Microbiome Project. So the Human Microbiome Project came along and basically mapped out the whole oral microbiome. So we knew pretty much all the different bacteria in the mouth. And what they found was that there are certain keystone pathogens, so certain bacteria, such as Porphyromonas gingivalis, that really, really would cause disease. And the reason they did that was because they acted in a specific way. So they would release what we call virulence factors, or enzymes, and these enzymes would then cause disease. So this is where we understood that, again, it's not just having the bacteria in your mouth, but it's about having the bacteria that's doing bad things in your mouth, as well as how your body's responding to those bacteria. And then in 2020 was the IMPEDE idea. And this was inflammation-mediated polymicrobial emergence and dysbiotic exacerbation. It's a very long sentence there. And this was the idea that actually disease and dysbiosis is triggered by inflammation. So the initial inflammation is what alters the environment, and that alteration in the environment allows certain bacteria to start acting bad. And that's where we start getting disease. So I guess the question is, should we only be caring about bacteria? And the answer is no. It's really important that we understand that it's not just killing everything out there, but it's really understanding how our bodies respond to those bacteria and how those bacteria are acting in our bodies. So really, I know, most of us here are maybe more towards restorative work, but in terms of perio, the cause of periodontal disease is bacteria, yes, but actually how your body's responding to that bacteria, and that can be dictated by your genetics, as well as certain risk factors as well. So we're going to now understand how is the oral microbiome formed, or a biofilm formed. And obviously, if we start to zoom inside all the way through to the mouth, we can then go onto a tooth surface. We're on a nice, lovely tooth surface. And the first thing that happens is you start getting your kind of small complex carbohydrates here, and they create what we call the acquired pellicle. So the acquired pellicle is kind of a bit like a sticky Velcro. So it's got these little dendritic hands which will grab onto the bacteria to create that first microcolony. And so we start getting our bacteria, and they start to clutch onto those dendritic hands, and we start getting our first pioneering bacteria causing a microcolony. So this is maybe a couple of hours after not brushing. And then bacteria, when they see some, more bacteria will start to come. So we start shifting from a microcolony to a biofilm. And so this is where we start seeing more and more bacteria kind of grabbing on and adding on to each other. And then next up is that actually there are so many bacteria that now, if you think about those bacteria which are at the base of the tooth, they don't have any access to oxygen, to any foods, they can't really see the saliva. So these bacteria, they're starving. And what happens is they actually start to mature and change, and they become usually a lot more pathogenic. And this is where we start to see these bacteria transition into more anaerobic bacteria because they don't need oxygen. And this is where we really start to see disease starting to form. And then what happens is you've got so much bacteria, so this patient's really not brushing their teeth, this bacteria comes, and there's just so much that it actually starts to dislodge and go from the tooth, and it travels all the way through, down through to the rest of the body. So why is the oral microbiome so important? And the first is we're going to kind of split it up into two. So the first is your local impact of an imbalanced oral microbiome. So these are your simple things. It's the stuff that we all know. So increased risk of decay. We know that there are certain oral bacteria which are really strongly associated with decay. And then also increased risk of periodontal disease. So again, we now understand that there are specific bacteria which are very strongly associated with periodontal disease. But on top of that, there's also a term called low-grade chronic inflammation and leaky gums. And low-grade chronic inflammation is the one that I'm really going to focus on. And the idea of low-grade chronic inflammation, or the actual definition, is a systemic status of chronic subclinical production of inflammatory markers. And this condition represents a risk factor for many chronic diseases. So basically, this is the constant firing of inflammatory markers at a low grade, so not too much, but this constant firing of inflammatory markers from the mouth through to the rest of the body. And this is where we see a really strong connection between the mouth and the rest of the body. And I always, when I have a patient in my chair, and they don't really understand the connection between, your mouth and the rest of your body, I'm like, okay, so imagine your eye was bleeding, okay? You probably do something about that, right? You'd probably run to the doctor and sort that out. And that is a really big sign of inflammation, of a problem. But for some reason, when our patients have bleeding gums, they don't really necessarily do much about it. But that is low-grade chronic inflammation, and that's the beginning of that connection with the mouth and the rest of the body. And then we go on to the other kind of how the mouth is connected to the rest of the body. And there are three kind of mechanisms that we now understand. So the first one is translocation of bacteria. And this is where you've got bacteria from your mouth, and either you can actually just, it can travel down to your lungs, so you literally just inhale that bacteria, or you can actually swallow it and it goes down into the stomach, or it can actually just go through the whole blood flow and go through your blood vessels instead. And this is where a lot of my research actually, and this is where I think a lot of my, kind of the beginning of my obsession with the mouth-body connection came, was from COVID. And so what we did is we did a lot of research, and we found that actually when a patient is immunocompromised, so they have COVID, they are in hospital, they are being intubated, no one's brushing their teeth, and maybe if they're lucky, a nurse might be going in there with a chlorhexidine sponge, maybe, but most people weren't doing that at the time. And that patient had perio, or had a lot of bacteria in their mouth. they would actually start inhaling that bacteria. And the biggest cause of death for most COVID sufferers was not actually the virus itself, but bacterial superinfections. So this is the idea that these bacteria would actually travel through down to the lungs and cause superinfections. And so that was what a lot of the research we found, was that these patients, when you unfortunately looked at their autopsies, they had oral bacteria in their lungs, and these oral bacteria were associated with things like gum disease. The second is metastatic injury, and this is the idea, so you've got your bacteria, travels through to the blood, and then it releases inflammatory markers and cytotoxic enzymes, and these will actually start to destroy your blood vessels, and they'll impact how your blood vessels will constrict and dilate. And this is where we start to see connections with things like cardiovascular disease, even diabetes, and again, it's all about blood flow to distal parts of the body. And last but not least, and I guess my favorite, if you can say that, is low-grade chronic inflammation. And as I said, that's just the constant firing of these inflammatory markers from your mouth down through to the rest of your body. And so these are just some of the mouth-body connections that we're now starting to understand. There we go. And now, to this day, there's over 50 systemic conditions which have been connected to the mouth. And I think for a long, long time, for the past kind of maybe, I don't know, 20, 30 years, there was a lot of speculation that actually, is it actually causation? Is it correlation? What is it? And actually, one by one, most of these systemic conditions are actually, we're starting to understand that there's a strong causative factor between these. But that's a whole, half-day conference that I do, so I'm not going to bore you and go through every single mechanism. But these were just a few of them. So how can we actually test the oral microbiome? And it's all about saliva. And so you can see a lot in your saliva. So actually, in the UK, saliva testing has replaced blood testing for prostate cancer because it is more reliable. We're starting to see the same with HIV testing, with hormone testing, so cortisol testing. Most of that's actually tested through your saliva. So all that saliva that you guys suck up every day, it's actually really, it's gold dust. So most of my patients, when they come into my room or in my practice, they know to not eat or drink for 30 minutes before their appointment because I will be probably collecting their saliva for some sort of trial or research or for something, basically. And so actually, I think saliva is an extremely important and underutilized medium. So you can see inflammatory markers in the saliva, you can of course see bacteria, you can see enzymes, and you can also see base pair mutations or genetics as well. And so this is a test that we have developed ourselves, and what we really wanted to understand was that host immune response, because I'd done a lot of testing, we'd done a lot of microbiome testing, and the problem was that you would see two patients do the same microbiome test, or two different microbiome tests, and they would come back with the same results. One would have raging gum disease, and the other one would be completely fine. And this is where we understood that, again, going back to what we were saying previously, it's about how that person is responding to that bacteria. So it's your host immune response, but also how those specific bacteria are reacting in your mouth. So we look at bacteria, we look at 10 base pair mutations, we look at the virulence of bacteria, so what factors and enzymes are these bacteria releasing. We combine it with the patient's medical history, their age. We built an algorithm to really understand and predict the risk of your common oral diseases. And then we thought, okay, well, how do we validate this? And I had lots of patients in my chair, and so we validated it with them. So we validated it with over 700 patients, and what we wanted to understand and make sure was that when the test says that you're high risk for periodontal disease, that that patient actually had periodontal disease as well. And then we thought, okay, well, this is great, but then, so you find out that you're high risk for periodontal disease. What do you do about it? And that's where we started to work with functional medicine practitioners, with nutritionists, and just other types of kind of healthcare practitioners who actually treat a lot of those conditions we were talking about, your chronic inflammation, high levels of specific bacteria, but they looked at it from a different angle, and we created those personalized recommendations. So, enough about oral microbiome testing. Now on to active prevention of disease. So I don't think it's enough for us to sit and say, okay, let's just watch active lesions and hope for the best. And as I was saying, unfortunately, for a lot of dentists, I think we're starting to see a new generation of patients who are not going to need as much restorative work as maybe our patients who are maybe in their 50s or their 60s. So what are we going to do with those patients? Are we just going to randomly start drilling every tooth because we need some money? Or are we going to not give them the right oral care advice so that they then form cavities? What are we going to do? And I think as a dental profession, it's great. We want to make sure that as few patients need something, but we also need to think of a way of actively preventing these diseases and making sure that our patients remain healthy. And so one of the first things, and one of this is kind of like the foundation of my practice. We have more hygienists than dentists. The patients see my hygienist more than they see me. And honestly, if a patient is seeing me more than the hygienist, then I'm starting to get a little bit worried. So for me, the hygienist, and we like to call them more health coaches actually, they should be the ones that your patient should be seeing all the time. And so how many of you guys know about guided biofilm therapy? If you could just raise your hands. Okay, so quite a few of you, but not everyone. So guided biofilm therapy is kind of like your replacement of a normal hygiene. I hate the term scale and polish, but a scale and polish. And the reason I don't like the idea or the name of scale and polish is because it completely undermines what a hygiene does. And a hygiene for me is actually disrupting the biofilm. It's reducing your inflammation. It's reducing your bacteria. It's improving so much of your oral health, and that's why it's the foundation of our practice. And so it's made up of 8 different steps, and essentially it uses a airflow device, which we're going to cover in a second. So what's the problem? So yes, we're definitely doing a lot better than maybe we were 60, 70 years ago, but unfortunately, 10% of our global population have severe periodontal disease. And we just touched that over 50 systemic conditions are connected with periodontal disease or poor oral health. And on top of that, periodontal disease is the 6th most common inflammatory condition. And that's after diabetes, cardiovascular disease, and the worst part of it all is that periodontal disease, in probably 99.999% of times, is entirely avoidable. But we don't really know how to treat that. And so the question is, are we not treating it well? So are we just not actually getting the outcomes that we're meant to? Are we not diagnosing it well? So is it that actually there's a lot more patients who start having perio, but we don't realize until they start losing teeth? Or is it that maybe there's a limit of access? So definitely in the UK, there's a huge limitation to access to care, and that's something from COVID. So we're still kind of suffering the consequences of us being closed for 3 months. We're still having issues with that, and I'm sure it's the same here. Is it that actually, perio is uncurable, poor prognosis, and we don't know what to do, and unfortunately that's just the luck of the draw? Is that the issue? Or is it that actually there are so many dentists and hygienists out there who are doing completely different treatments, and so there's varying treatments out there. It's very, very subjective, and we don't actually know, there's no proper guideline of exactly, how to treat it. And these are just questions. I'm not saying that any of these are correct or incorrect. And so guided biofilm therapy, for me, is a really nice systematic approach to treating the gums. And it could be for just gingivitis, it could be for periodontal disease. And the reason I like it so much is that it uses airflow. So an airflow which has got these fine little particles of erythritol in it. And the erythritol is just rough enough or big enough for it to remove staining and to disrupt the biofilm, but not rough or abrasive enough to actually start damaging the teeth. So actually, if you compare, for example, rubber cut polishing versus using an airflow with erythritol, you can see a huge difference in the abrasiveness of polishing versus using your erythritol. So we don't even have any polishing at our clinic. And on top of that, it removes your biofilm really safely and very comfortably. Erythritol as an actual kind of chemical in itself has been shown to inhibit strep mutans, and it's also naturally antioxidant, naturally antibacterial, and anti-adherence. And so what we did is we actually did a study on it, because I was at the time, this was in 2023, I was working at 2 clinics, and one of my clinics had GPT, so we were doing guided biofilm therapy, and the other clinic was doing your normal kind of cavitron and polish situation, ultrasonic and polish. And at the time, I was still doing microbiome testing, and I was collecting all these patients' saliva, and I was trying all these different products out on them. And for some reason, the patients who were at my clinic with guided biofilm therapy were having awesome results on their oral microbiome, and they were also having much better results with their perio. And my patients who were in the other clinic weren't having as good results. So I was wondering, what's the difference? I mean, I'm the same clinician, I'm doing exactly the same thing. And we realized that maybe it could be that in that clinic we're doing guided biofilm therapy. So we did a study, and we basically tested these patients' microbiomes right before they had a GBT, and then 3 months later, right before their next session, and then immediately after. And that way, we could see whether or not the microbiome changed within a 3-month period, but also immediately before and immediately after doing guided biofilm therapy. And what we found was that the main kind of periodontopathogens, such as your AA, your P. gingivalis, your T. forsythia, your T. denticula, all of these bacteria, you can see this kind of really nice decline going downwards. And this is showing that it is removing those bacteria, and not just in a short term, but also over a long term. And that's because of the anti-adherence properties of the guided biofilm therapy. And so what we concluded was that GBT significantly reduced levels of the majority of periodontopathogens in both patients with periodontal disease and those without in short and long term as well. Now, on top of that, you guys might say, okay, that sounds really cool, but how about all of this beautiful work that I'm creating? I want to make sure that this GBT and this erythritol is not damaging any of my restorations. And so these are some papers that have come out. And the first is to do with composites. So they found that sodium bicarbonate air polishing caused notable material loss. And so your airflow does not use sodium bicarbonate, not the plus powder. The plus powder is erythritol. And airflowing with your erythritol was far less abrasive and had a minimal effect on the microhardness. So they actually concluded that if you were going to use anything, you should be using airflow. And then we go to our GICs, and your GIC, they found that actually that small particle erythritol from the GBT is the most gentle powder compared to any of the powders that they used, and it didn't worsen the roughness compared to any of the others. And then we move on to active prevention from a different way. So this is cure, don't repair. And this, I think, is a really, really exciting new kind of development in dentistry. So how many times have we seen interstitial caries on a patient, really early decay, and we say, oh, yeah, you know what, let's just watch and wait, floss a little bit more, maybe we don't need as much sugar, and we'll see you again in 6 months. And some patients do come back in 6 months, and maybe it has developed, maybe it hasn't. Other patients won't come back for 6 years, and then when they come, they need a root canal. So we're not really monitoring that decay very well necessarily. And then there are other products that are available for interstitial caries. So for example, your Icon, which is effective, but in my opinion can be quite painful sometimes for the patient. And by the time you separate the teeth, and then you put the rubber dam on, and then it's quite a process. And at that point, the patient, I had one patient, this is when I changed, I'm sorry, I love Icon, but they said, at this rate, I could have just had a filling. Like, it's quite painful for them. And so, again, Icon, I think smooth surface is fantastic, and for proximal has its time and place, but this, for example, a child who you can't put a rubber dam on them, you can't separate the teeth, this would be a far better alternative. And the reason for that is that it uses a peptide technology called P11 form. And this technology basically allows for enamel regeneration from the base of the lesion upwards, so the depth of the lesion, whilst also keeping the natural tooth structure. And again, what's the problem? So more than 80% of initial caries is on proximal surfaces. One of the problems is that we're often not actually seeing it with the types of x-rays that we're taking, or different people are taking different x-rays at different angles, so we don't always see interstitial caries. But also, there's a lot of early kind of white lesions that we're seeing on these patients, and a lot of the time this isn't being treated. A lot of people in these specific situations, they say, oh, it's just a white lesion, but actually that's it is early decay. So are we doing anything about it, or are we just telling the patient just kind of leave it and that's it? And so on top of that, if we were to restore every time we had early lesions or early decay interstitially, then we would be removing a lot of healthy tooth structure from our patients for a very small amount of decay. So what can be the answer? And that would be cure, don't repair. And then we go to our oral hygiene prescriptions. So again, that idea of one size fits all is not enough. So when we go back to that kind of broken tooth that we had earlier with the massive amalgam, and again, it's not one size fits all. So for one patient, you're doing an onlay. For another one, it could be a crown. For another one, you're doing a GIC. Another one, you're doing a filling. So why is it that for a lot of oral hygiene recommendations and even antibiotic prescriptions, I don't know about you guys, but the way I was taught was that, okay, patients got perio, you prescribe them this antibiotic. Patients got pericoronitis, you prescribe them that antibiotic. But we don't really do any more than that. And unfortunately, antibiotic resistance is on a rise. And we're not necessarily doing too much about that and trying to personalize and understand when patients need it or when they don't need it. And so this is kind of new and exciting things. It's not out on the market, but I'm very excited. And this is the idea of kind of precision periodontics. So it's the idea of potentially we can start to prescribe specific antibiotics for specific bacteria. So this was developed at the Forsyth Institute, and this was for Fusobacterium nucleatum, which is a bacteria associated with periodontal disease, and they found that they were able to effectively eliminate Fusobacterium nucleatum from the oral microbiome without impacting the rest of the microbiome. So we're now starting to see these very precise antibiotics which are able to just kill the bacteria that they need to. And interestingly, they're now using this antibiotic for gastrointestinal, or gastroenterologists are starting to trial this antibiotic on their patients. And the reason for that is that they found that over 50% of patients who had colorectal cancer had high levels of Fusobacterium nucleatum in their mouth. And so they're now trying to see if they can knock out Fusobacterium nucleatum and reduce the kind of severity of that colorectal cancer. And then antimicrobial mouthwashes. We were speaking about this earlier at the coffee break. I like antimicrobial mouthwashes. I think there's a time and place for all of them, but we need to be precise and specific with who uses it, for how long, and when, okay? And so the kind of blessing and curse of us doing all this oral microbiome testing is that I sit there and I look at absolutely every single report and I sign it off before we send it to the patient. And every time I'm seeing a patient who's on your really strong antimicrobial mouthwashes for absolutely no reason, they've just been kind of seasoned to do that, they just think that's what you do, they just have a microbiome which is extremely low in diversity. They have no bad bacteria, but they also have no good bacteria either. And so for them, if they stop taking that antimicrobial mouthwash, what's going to happen afterwards? So again, we need to start understanding that you can't just give everyone the same antimicrobial mouthwash and not tell them when to stop. We need to, I think of antimicrobial mouthwashes as kind of like an antibiotic. We need to give them and prescribe that specifically for them. And so there's also been some research to show that potentially there are certain antimicrobial mouthwashes, which include chlorhexidine or CPC, which have been shown to increase your blood pressure. And so this is where we start seeing the connection with your nitrate, dietary nitrate to your nitrate-reducing bacteria. And this is the idea where you've got specific mouthwashes which are actually killing those bacteria, which convert your nitrate into your nitrite. And when that's not available, then you're not going to have nitric oxide, and that will impact vasodilation. So we're seeing these patients who have an increase in their blood pressure just from taking these specific types of mouthwashes. And again, time and place for every mouthwash, but this type of person needs to understand when to stop taking that mouthwash. And so actually, maybe we should be avoiding mouthwashes unless necessary. Maybe we should be telling patients to increase their dietary nitrate. So things like your celery, your beetroot, your rocket, those types of things which actually can, naturally increase your dietary nitrate might be a lot better for your blood pressure regulation. And also if that's patients using that mouthwash to offset the impacts of that mouthwash. And then we go into, should it be antimicrobial? Should it be biomodulation? And this is just hopefully making you guys think a little bit about things that you're doing all day, every day, and trying to understand different things that we might be able to implement into practice. And so again, antimicrobial mouthwashes, they usually just kill everything, and they're very strong. And so there's now a kind of new trend that actually we shouldn't be killing bacteria, but we should be modulating how those bacteria act inside that person's mouth. So, for example, there's this product, perio, which we're just testing out for them now, and it's able to not kill bacteria necessarily, but stop your keystone pathogens like Porphyromonas gingivalis from doing bad things. So the bacteria stays in your mouth, it's fine, but it stops doing those bad things and releasing those toxic enzymes that are causing all of those problems. And they're showing that that can actually have a knock-on effect and reduce your periodontal disease. Or, for example, Curoprox Zero, which actually has no chlorhexidine, nothing strongly antimicrobial, but it actually mutes the virulence of your key pathogens through quorum sensing. So again, it's not killing anything, it's just stopping those bacteria from doing bad things. And so we're going to quickly kind of cover a case report of what treating a patient with poorly treated gum disease looks like at my clinic, and also what hopefully could be potentially the future of dentistry for some people. So we did a microbiome test on the patient, and we found that they had very high levels of your key pathogens, so your Porphyromonas gingivalis, your P. intermedia, your T. forsythia. So these are the big bad guys that you don't want really in your mouth. They had very high levels. Then we look at hundreds, but those are your top ones. And then we looked at genetic mutations. So we look at 10. These were for the risk of decay. So we're just looking at these specific mutations. No real problems with decay. But we go on to periodontal disease, and we see specific mutations here. Now, for me, any time I see a patient who has the TNF gene, I get a little bit nervous. And the reason for that is TNF is tumor necrosis factor. So what this means is this type of patient, they will release a lot more tumor necrosis factor, which is an inflammatory marker, than your average patient. So this is where maybe, for example, we've all had that patient who brushes 20 times a day, has every TP brush in her handbag, she does everything right, but somehow she's got raging gum disease. And you're like, I don't know, maybe it's genetics, or I don't know. We don't really know how to answer that. And then it's usually the case where her husband, doesn't brush his teeth, smokes 20 cigarettes a day, and has absolutely no problems. And a lot of the time, the type of patient is one who has a TNF mutation. And so for that type of patient, even the smallest amount of bacteria, the smallest amount of stress will cause them to release a lot more inflammatory markers and respond in a much more aggressive way. And so obviously the prediction for that patient was that they had a high risk for gum disease. And so we gave them a couple of treatment recommendations, and that varied from using omega-3 to vitamin D supplementation, to using the right toothpaste specifically for that patient. We even told them what type of diet they should be having. We said to them they should be having a hygiene every 3 months on top of the treatment that they need for their periodontal disease. We told them what gels they should be using in between their teeth on their interdental brushes. We even told them, exactly what types of supplements to be taking. And we even recommended to them that they should test for diabetes. We need to test their vitamin D levels so that if we're going to be treating this patient, they have the best opportunity of having a good prognosis. And then we also looked at supplementation. So for this patient, what we found was that because they have a TNF mutation, so for tumor necrosis factor, what we want to do is we want to reduce their TNF production as much as possible. And so actually, resveratrol is a really great recommendation for that. And this is from our functional medicine doctor. He said, oh, you know what? I do blood tests all day, and I have these patients who have really high levels of TNF, so I recommend that they use resveratrol. So we thought, okay, that sounds really cool. Why don't we do that for our patients as well? And so we did exactly the same thing for this patient. We did, even it's in red wine. We didn't recommend red wine to the patient, but grapes, resveratrol, all of those types of things, trying to reduce the inflammation as much as possible. And so this is our results that we got. And this was a couple of months ago, actually. And so what you can find here is our virulence factors. And so virulence factors are those specific toxic enzymes that are being released from those bacteria. So this is from Porphyromonas gingivalis. And so we found that on the red is before and the green is after. So we got an amazing reduction of virulence factors over those couple of months. And you can see as well here, the reduction from immune evasion, metabolic toxicity, inflammation, proteolysis, all of that reduced very significantly for this patient. We also looked at all the other bacteria which they had, and again, orange is before, blue is after, and you can see there is no blue on the far right, and that's because there was no bacteria. We were actually able to remove all of that. And the most important thing, by the way, is we didn't use antibiotics for this patient at all. And this was their pocketing. So, I mean, this patient, everyone thought I was a dreamer, and he's still very much under supervision, but the tooth was vital. So we decided we were going to actually splint it. We did minimally invasive non-surgical treatment on it, so minced. And what we were finding, and it's early days, but I keep on taking x-rays, is that actually we're starting to get a little bit of bone regeneration on that patient as well. And you can also see from the pocketing perspective, so the dotted lines was before and the dark purple lines is after, that we were getting amazing results from this patient. And again, this patient had been treated numerous times by another dentist, and they were never able to really understand. They just said, take half your teeth out and let's place some implants in there. So I guess my conclusion is that one size fits all is the dentistry of the past. And I think what a lot of you guys are doing here, the beautiful work that you guys are creating, is so personalized, actually. You guys are, bioemulation, all of this, it's actually extremely personalized. And I hope that that is the future of restorative dentistry. And I hope I gave you a little taste of what I think is the future of maybe more preventative dentistry, so that patients don't need to get to a point where we need to be restoring any of their teeth. And the idea that actually personalization and precision is the future, and that's being fueled by generational change. So all of these patients who are wearing their wearables, who want to understand everything, we need to speak their language. And in order to speak their language, we need to translate all of the qualitative things that we're doing into quantitative data. And we can use artificial intelligence for that. And so quantitative diagnostics should be the backbone of dentistry. So thank you very much for having me.